Hope you are well. Robbie is in the air somewhere heading towards Thailand in what I consider the best airline in the world, Singapore Airlines. So he sent me some pictures. He was living life large, and we're really proud of him for that. Deborah, do we have a case presenter for today?
Yeah,
Awesome.
Amal will present a case. Amal, do you want to say hello?
Hi everyone. I'm very excited to be back to present another case today. I'm a second-year resident, and I already presented the case before, and I'm happy to be back.
Amal, where are you?
I'm in Georgia.
In Georgia. Okay, very nice.
Yeah.
Thank you for joining us and preparing another case. Very excited. And then who is teaching today, Deborah?
Ombesh will
Hi,
be.
yeah.
Oi.
Oh, I'm
Hey,
gonna say
everyone.
hi. Hi.
Hi, everyone. Good morning. I'm really excited to be here. We're all missing Rabi. And I just want to give a shout out to Amal, who is post her night call. And I think she's setting a role. She's being a role model for all of us, interns to be. I think it's amazing that you have that energy. So thank you for joining us today.
Yeah, thank you for having me.
All right, Amal, be kind to me. I'm missing my smarter brother.
Okay, I'm gonna start with the chief complaint, which is altered mental status for the past 2 days. So this is a patient I saw recently who is a 60-year-old male. And history was taken from his partner because he was found to be altered. Mainly, he was found on the floor in a homeless shelter transferred by AMS. He was found on the floor and he defecated on himself. And so he drinks 4 beers every day with some shots of vodka. That's what his partner said. And he's been confused for the past 2 days, but it just got worse. And then the partner came one time and found him on the floor. So he called the AMS. That's the only history we had. So we tried to ask the partner about like review systems, and he said that the only thing he told him was shortness of breath, and he also noticed that he was having loss of appetite, weight loss, and was just acting different for the past few days.
All right, Amal, is this pause number 1?
Yes.
Okay, great. This is actually a very rich history, and it already highlights one of the most challenging things in tackling confusion, encephalopathy, altered mental status, however you want to frame that term, is that so much of it depends on the HPI, but the patient can't communicate the HPI. And so you're reliant on the loved ones, the family, friends, partners. It's not as bad as syncope as a complaint, which is often unwitnessed. And you're really trying to understand what happened before the event, what happened during the event, what happened after the event. But in this case, I think that's the challenge we're going to have. And I really firmly believe that the majority of diagnoses are achieved by getting a good history. Not so much the physical exam, it's important, but not as important as the history. And when you're lacking that history, it becomes very difficult and you become more reliant on your exam and on your diagnostic tests. For this patient, I think that if you're playing base rate, you would say, oh, could he have drank a little too much? And that drinking too much caused him to be confused. Also, we know that alcohol causes inflammation of the colon and can cause you to have increased bowel movements. And that would be a way to tie things together. Although that's most likely, you still have to think about other scenarios. More recently, I've been using the 3L mnemonic for like framing my diagnoses, and that includes likely, lethal, and less likely. And this honestly is the core foundation of a good diagnostic framework. So we are gonna use, Amal, our favorite missed mnemonic: metabolic, infectious, structural, and toxin. I would frame the time course as acute encephalopathy in someone with a background of alcohol use disorder. And in that frame, the first thing I would do on the scene is get a point of care glucose, knowing that it probably will be low, but it has to be very low to cause confusion and symptoms. Then I would be getting a urine tox screen. I would get an alcohol level, but I would prioritize within that MIST framework metabolic and toxin related processes. So you're going to get the glucose, you're going to get the urine tox, you'll look at the sodium, you'll look at the calcium, you'll look at the BUN. Then I'd be like, okay, he was found pretty much down. Did he have head trauma? I would have a very low threshold to get a CAT scan to make sure he doesn't have like a subdural hematoma as a consequence of the confusion, and then maybe later exacerbating the confusion. And then the other S that I would consider in that MIST, we don't often include it, it's structural, would be seizure. So like, could someone have seizure and have post-ictal confusion and have bowel bladder incontinence? It's possible. And the last thing I'll say is anytime I see stool next to a patient, I just have to think about myelopathy and bowel incontinence. I just have to think about it, though I don't think that's likely. So what I encourage all of you to do when you're approaching patient care is like, really, you can think broadly. You don't have to test broadly. Think most likely, but also think lethal. And so in this patient, I'd be like, alcohol use disorder, confusion, not acting himself. Is it the alcohol? I have to check a glucose. Is there another toxin on board? Let me make sure there isn't anything structural. And then I would let the exam, the labs, and the rest of the data guide my next steps in tackling this case. Back to you, Amal.
Okay, so we're gonna go to the history. So history was limited to just what the partner knows. Past medical history has known history of alcohol use disorder, anxiety and depression, and hypertension. Not on any medications at home. Family history, hypertension, father, and heart disease in mother. Social history, smokes cigarettes, denies any substance use, like the partner says that denied any substance use, and he drinks 4 beers every night and some shots of vodka. So he has a poor social situation, lives in a homeless shelter, and the partner lives in the same homeless shelter, and no known allergies. Do you want to comment on this before I move to the physical exam?
No, I actually have no comment to make. I think it would be a mistake to put too much weight on the fact that he's living in a shelter. And, we often include that as like, oh, they're at risk of this and that. But I'm not doing that yet. Right now, I think the physical exam is going to be most helpful.
Yeah. So for physical exam, I'll start with vitals. Temperature was 87.8. Heart rate was 92. Blood pressure was 78/58. Respiratory rate was 17. SpO2 was initially 95% on 4 liters and then went up. So I'll say this is like was initially on admission, and then I'll talk in a bit. So he deteriorated throughout the admission and was later on 14 liters, 95% on 14 liters. And then for general, he looked chronically ill, lying in bed. Normal cephalic dry mucous membranes. Cardiovascular was irregularly irregular, but no murmurs were heard. Pulmonary, non-labored breathing and diffuse crackles were heard. Abdomen, normal bowel sounds, non-distended, non-tender, and no masses palpated. For neuro, he was arousable, oriented ×1, GCS was 15 and no focal neurological deficits. And for skin, he had non-blanchable purpuric rash in the lower extremities. So, yeah.
Amal, you said non-blanching rash, is that correct? Okay. Is this the second aliquot or third aliquot? This is a very rich aliquot.
Yeah.
Very, very rich aliquot. And this is actually going to be a very interesting case. And I want to just show you all what my mind is doing. And if you look at this case, if there was one abnormality you had to identify, what would be that abnormality? Like, what would you frame or anchor your reasoning around? And where you would I would anchor my reasoning is in the temperature. Like that temperature is very, very low. Hypothermia. Can someone convert that to Celsius for me as I'm speaking? That'd be helpful. Include it in the chat.
31.
Oh, what is it, Amal?
31.
Oh, thank you for doing it quickly for me. So the question becomes, why does someone become hypothermic? And we're going to use that as our center, and then we're going to try to explain the other findings that may be a consequence of the hypothermia. And like, for example, let me just jump right to it. People that get so hypothermic, they're at risk of coagulopathy. And with coagulopathy, you're at risk of bleeding. And what Amal is describing in the lower extremity is basically bleeding in the skin. Those are probably representing petechiae. And I would imagine they're non-palpable, but you always have to entertain the idea of like, is it vessel inflammation? But I think this is more likely going to be some kind of coagulopathy related to his moderate hypothermia. Believe it or not, this is moderate. You can categorize hypothermia as mild, moderate, or severe. And then I look at his other finding, the lungs. When someone is so altered and down, they're at very high risk of aspiration. And I believe hypothermia can also make the vessels leaky. So if I'm using hypothermia as my center, it can start explaining the other findings, meaning it could explain the coagulopathy and bleeding in the skin. But let's say if I reverse that and said, okay, if I had a vasculitis, how could that explain such profound hypothermia? Just think of it, like, of course you can have altered mental status with vasculitis, but hypothermia, it would be difficult to do that, wouldn't it? And then the lungs, like how could think of all the causes of crackles and fluid filling the alveoli, water, pus, blood. Like what cause could cause this degree of hypothermia? Yes, sepsis usually causes increase in temperature, fever, but it can cause lower temperatures, but like we've taken care of so many patients with infection. So you see, it's kind of difficult for me to go from one of those as my anchors to explain the temperature status. But if I use the temperature as my main anchor, then I can start explaining the other findings. There's only one thing you have to be very careful about here, and that's this, that people who are severely altered, they can find themselves in a cold environment, and then they can develop hypothermia because the body can only do so much for thermoregulation or thermohomeostasis. And what I'd like to do now is show you guys something, because hypothermia isn't something I see often or think about often, but I've thought about it before and I have an approach. And that's what I want to show you. I'm actually looking at here. Did my screen? Yeah, it's up there. Okay. So here, whenever I create one of these scripts, I just start with what is normal physiology, and then ultimately low temperature is either it's determined by heat loss and decreased heat generation. Like there has to be an imbalance in these two domains. And then I go a little bit into just like the physiology of heat production, where it starts and such. But here's interesting. Look at this, Amal. Who's at risk? Alcohol use, homelessness, psychiatric disease. It's almost as if you read my glass note before you created it. It's like this patient has all the risk factors. What is it? It's basically decreased tissue metabolism and decreased neural activity. And then here, this is how you can categorize it. Amal's patient is in the moderate hyperthermia, where you can read some of this text, not that relevant, but here are the common abnormalities that you might see. So we're going to be looking for glucose, lactate, coagulopathy. You can get these. I saw an Osborne wave before on an EKG when someone's hypothermic. It looks like a J point elevate. It's like a little ditzel after the QRS and the chest X-ray. So now I want to show you something else that I think is even more relevant. Here's the hypothermia causes. This is our 5-step approach. Repeat the temperature, make sure it's right. Does the hypothermia correlate with the clinical syndrome? If not, look for an alternative diagnosis. Right now, I'm going to say it does, but we have to be open to an alternative diagnosis. The most common causes is like someone is just out somewhere in the environment and becomes altered and then becomes hypothermic, or they have a drug exposure. And then the common things that you don't want to miss is like sepsis, as I mentioned, less likely as hypothermia, a TSH, and cortisol. And then step 5 is other causes. And then ultimately it comes down to this beautiful figure created by the mathematician: decreased production or increased loss. So we may come back to this figure, but as you can see, the base rate: exposure, sepsis, hypothyroidism. We'll be thinking about adrenal insufficiency, and he might be malnourished because of his alcohol use disorder. So just look at that figure for a second. I think we have a good approach, and then we should get more data. And the other thing I just want to say is that how you manage this is really important too. Like, you have to be cautious in how quickly you rewarm the patient, because if you rewarm them too quickly, you can have consequences of that, whether it is in their neural activity in the CNS, their cardiac activity. Like, you want to follow a specific protocol. And when you think about rewarming, you can do it external. So everyone's going to put blankets on this patient. You can have like a blanket warmer, electric blanket warmer, but you can also warm internal through the IV. Like, you can give warm saline, or you can shoot stuff through the Foley catheter into the bladder. So it's just important to recognize there's multiple ways to warm this patient up. But I have to emphasize something so important. It's not so much that the warming the patient is going to cure the problem. We still have to identify what drove the hypothermia, but we should treat the hypothermia in a very stepwise manner of like 0.5 to 2 degrees Celsius, I think, rise per hour. And those are the methods that you have. Amal, I'm going to give you back the mic. Any reflection on what I said, or any other thoughts you want to add there before you give us the next aliquot?
Yeah, so basically what was surprising to us is we didn't really expect this patient's like oxygen requirement was going up like very drastically. So he came in, he was on 4 liters, and like next morning was on 14 liters. We initially like attributed to alcohol use, and we're thinking, yeah, maybe this is alcohol use. But then when we saw the temperature, we're like, maybe like we should like broaden our differentials and include what you said. And then the oxygen requirement was going up, but like that was like a bit interesting to us because it was like very drastic. So
And I
yeah,
have to say something with that right there is that, yeah, if you look at the severity of the lung pathology, basically this is ARDS. Like, you'll look to make sure that you'll get a proBNP, you'll get an echocardiogram, but this is acute respiratory distress syndrome. And the most common causes, like, it's rapidly progressive, it's happening acutely. The most common causes of that include aspiration, pneumonia, and sepsis. So now all of a sudden we're thinking, could there be sepsis? Could the lung be at hook? And could that be explaining the hypothermia? And can you have a DIC that's explaining the petechial rash in the lower extremities? But you also have to think about ARDS mimics, and this is where you have cardiogenic pulmonary edema, but also just toxin exposures to the lung. And you can have a pneumonitis, like a hypersensitivity pneumonitis. You can have like drug-induced pathology of the lung. So this rapidly progression is just frames it as ARDS, and probably this patient's going to need intubation soon, because with this kind of like, even if you use BiPAP and it's not heart failure, it's not COPD, it's really not a bridge to anything. And I bet you the hypothermia is exacerbating it. But again, like, I think ultimately, like, the answer of the hypothermia is probably going to also answer what's driving and everything else, and at least at this juncture.
Yeah, I completely agree. When we saw like the increase in oxygen requirement, we're like, okay, possible ARDS. So I'm gonna go to the labs now. White blood cell count was 13,900. Hemoglobin was 7.6, and platelets were 54,000. So chemistry, sodium was 135, potassium was 4, chloride 105, bicarb 18, BUN 98, creatinine 1.23, baseline is normal, glucose 88, calcium 8.4, and magnesium 2. AST was 63, ALT was 17, alk phos was 78, and albumin was 2.6. GFR was 54. Troponin 4 normal. Do you want me to go to the imaging?
Please.
Okay. So EKG, AFib, not an RVR. Chest X-ray on admission showed no acute cardiopulmonary disease. And then, so we did like serial chest X-rays. One day after admission, it showed asymmetric ground glass opacities throughout the left and right lung. And then we did one like a few days after, like 5 days after, and it showed diffuse bilateral interstitial and alveolar opacities. Echo was done, and it showed it was normal. Ejection fraction was 60 to 65%. And then CT head showed no acute intracranial abnormality. We also did a CT chest, and it showed bilateral pleural effusions with passive bibasilar atelectasis and patchy ground glass and consolidation throughout the aerated lungs.
All right, Alma, you ready for that? This is really, it's so fascinating. And if you recall, like when we were in that first aliquot, of course, like thinking alcohol, but then you have to look at the rest of the presentation, the exam. This is scary. It's frightening. This patient is very, very sick, and you have to act quickly. I always think about like treatment and diagnosis, like how quickly it needs to be achieved. I correlate it with how quickly the patient is presenting. And this patient is like acute and rapidly deteriorating. And we can start right with the CBC. And when you're interpreting cytopenias, when you have one cytopenia, you're likely in the periphery. When you have two, you can be in the periphery or the marrow. But one thing you should reflexively think of when you see a thrombocytopenia and an anemia is a microangiopathic hemolytic anemia. Like, you remember when we talked about likely, less likely, lethal? The causes of MAH can be lethal, so you must consider it. But you can easily explain, like if someone has a very low platelet count, not 54, but let's say very low, they can bleed and have anemia because of their thrombocytopenia. Or you can have something suppressing the marrow that causes bicytopenia. Here, the elevation in the white count really heightens the possibility of peripheral destruction. And so when I do that, I'm like, okay, could this patient be having hemolysis? I quickly looked at the AST and ALT, and I'm like, oh, the AST is higher than the ALT. And AST is ubiquitous throughout our cells. ALT liver is more specific to the liver. So when you have a ratio that's greater than 2 to 1, you have to be entertain extrahepatic etiology, which then brought me to the bilirubin to see if there was like an indirect hyperbilirubinemia. But for now, with this data we have, this is peripheral destruction. until proven otherwise. And then you have to get a peripheral smear and a reticulocyte count. On that peripheral smear, really what I'm going to be looking for is schistocytes, because if there is even a single schistocyte, then this patient is, yes, exactly, one schistocyte, then this patient is in a MAHA. And whenever you have MAHA, there's a lot of causes of MAHA, but there's like the three that dominate. And those three is TTP, HUS, and DIC. There's other causes that you can look at or figure online. In this patient, you know, with the hypothermia, with the leukocytosis, with the compromised immune system, I think infection becomes primary consideration. And so DIC, and with DIC, half of this time the smear doesn't have schistocytes. So now my brain said DIC. So now I want a D-dimer, I want an LDH, I want a fibrinogen to look to either strengthen that hypothesis. But then I look at the kidneys and the kidneys are off. So if the kidneys are off, could this be HUS? And am I dealing with like a life-threatening microangiopathic hemolytic anemia? The interesting things about TTP and HUS, usually the lung isn't heavily involved. And here the lung, it's just giving us so much signal. It's saying like, look, I'm not a bystander. Like I'm worsening by the minute. I need you to pay attention to what's happening here. And so then you're like, okay, is it white cells, red cells? Is it fluid? It's unlikely to be cardiogenic edema based on the echo. But remember, people can have diastolic heart failure with a normal EF and have cardiac decompensation. So that pro-BNP would also be helpful. And especially because this patient has pleural effusion and the heart pleural effusion. So edema is not off the hook, but less likely for sure in this individual. And then once you start thinking red blood cells, which you have to consider with the anemia and the thrombocytopenia, you start saying, could he have like a pulmonary renal syndrome? Because the creatinine is, you know, the disproportionate between the elevation in the creatinine and the BUN is probably decreased muscle mass. So you would look at his BMI, he probably is malnourished. Creatinine comes from the muscle, but if you don't have much muscle, your creatinine is not going to be that high, but your BUN will still be elevated. And here his BUN is quite elevated. So I would quickly think about the pulmonary renal syndromes with a specific attention to the ANCA-associated vasculitides, because he has that rash on his lower extremities. The lower extremity is small to medium vessel. GPA and MPA, and even EGPA, but MPA and GPA, so pulmonary, renal, cutaneous, and is that diffuse alveolar hemorrhage? So now my mind is saying, boy, I would really like a BAL in this patient, but as of now, he's too decompensated, unless he gets intubated. If he gets intubated, then you have to do a BAL, and you want to see, is there any evidence of diffuse alveolar hemorrhage, but you also want to evaluate for infectious etiologies. You can see like all the direction we can take this case. As of now, my frame, 60 middle-aged man, alcohol use disorder, here with confusion and a rapidly progressive pulmonary syndrome with bicytopenia, thrombocytopenia, anemia, concerning for DIC. So I think almost in real time, how I would manage this patient, I would give them antibiotics, broad spectrum for sure. I would get the peripheral smear, the reticulocyte count, the LDH. I have to look for schistocytes. I think DIC would be leading the consideration, but I have to be open to hypothyroidism because of the temperature, and then just an aspiration event, and then ARDS. And yeah, and a UA is going to be really important as well, just to see if there's any protein or red blood cells. It's so tough. I just want to let you know, in my brain right now, many things are happening from like, is it the hypothermia causing the DIC, causing these symptoms? Is there a vasculitis that's causing the kidney, the lung? Is there an infection that's triggering everything and causing this patient to be quite sick because he is immunocompromised? So the things I can treat for is just antibiotics. If there's a schistocyte, I would get hemonc on board to just, you know, once you start thinking TTP, HUS, you have to think about Plex. But right now, infection would be leading the hypothesis. And then unless something comes back like hematuria or diffuse alveolar hemorrhage or something like that, but very sick patient, very, very sick patient.
Yeah, I completely agree. Patient was very sick. He's DNR, DNI, so we couldn't intubate. So we're thinking the same thing, DIC, ARDS, likely sepsis. We did reticulocytes were elevated, LDH elevated, and peripheral smear did show schistocytes. And then TSH was normal. So we're not like thinking myxedema coma or anything else. So we also did obtain a UA, which showed like leukocyte esterase positive and nitrite positive. So it was like suggestive of a UTI, and urine cultures later grew and Enterococcus fecalis and Staph longidineus. Yeah. So yeah, so we were thinking that this is likely a urinary, like severe sepsis secondary to a urinary tract infection, which caused ARDS and DIC. And we did treat like with broad spectrum antibiotics.
Yes, I think that this is where you have to be cautious. And I say cautious because you have to ask the question, does the positive lab result explain the clinical presentation? And here we know with the, none of us even thought of a urinary tract infection, of pyelonephritis. And in general, I think a really good thing to think about is that UTIs rarely even cause fever. Just like when I say UTI, like a simple cystitis. Remember, the urinary tract is you have the kidneys, you have the bladder, the ureters, the urethra. So when we say UTI, it's so non-specific. It's like saying RTI, respiratory tract infection. It could be anywhere. But if you have a simple cystitis, it's unlikely to cause SIRS. It can, but very unlikely. And even when you think about pyelonephritis, like the patient got a CAT scan, you would be looking for perinephric stranding, and you would expect the patient to be bacteremic. Like it would be just, it's very hard for my mind to say that a UTI led to this devastation of DIC, ARDS, and like someone almost on their deathbed, unless we had like a bacteria that was isolated in the blood. So I look at that urine culture, but I almost am like, that's not enough to explain this type of deterioration. Like that, Enterococcus is an organism that can cause UTIs. And one of the clues to the, yeah, it can cause it, but I just am not convinced that that's what's happening here. And so I step back and I do like the frame of ARDS and DIC, and the patient's rapidly progressive, but I'm just worried, is there something in the lungs that we're missing? Because it seems like our center of gravity in terms of clinical presentation is centered around the lungs and the hypoxemia. So I'm giving this patient broad spectrum antibiotics. It's a little difficult that, you can't do the intubation and he's too sick, I think, for a BAL. And so you're left with saying, what else could this be? And is there anything else that I might be missing? And here you're like, okay, he is in a shelter. He is immunocompromised. He is exposed to TB. Could this be tuberculosis? But TB usually doesn't present like this. But you should never say never to tuberculosis. It can have so many types of presentation, but it would be quite odd. So I'm just trying to think, what would I do for this patient? I would definitely I'm sure you got this, Amal, like a respiratory viral panel, just to make sure this is not COVID-19 or, a typical viral infection. I would get an HIV test just to see if that's the broaden to consider immunocompromised or opportunistic infections. But yeah, I'm just worried. Like, I think DIC, ARDS, sepsis, but I still have sepsis of unclear origin. And then the mimickers of that, just given the schistocytes, you have to consider TTP and HUS. And TTP and HUS, it's like, yeah, like it's very, very tough. So I actually might even get my Hemon colleagues on board earlier than later because those those conditions can be triggered by infection too, like HUS by Shigella, TTP by HIV. And that's where we have to be a little cautious, because if it's TTP and you miss it with the altered mental status, the renal insufficiency and stuff like that, the patient will die. So time is going to be of the essence. So how did he do, Amal, over the day after getting these antibiotics?
Yeah, unfortunately, when the partner saw him deteriorating, he decided to like withdraw care, and palliative care was consulted, and the patient passed away. So yeah, so he did, I forgot to mention, he did also have bacteremia. So that adds to the story.
Got it. And his bacteremia was Enterococcus.
Mhm.
Yeah, so that explains everything, folks. I'm sorry the patient passed, but I'm also very happy that the patient had their wishes, enacted in the hospital. Like, this patient during a clear mental state says, I don't want to be on a ventilator. I want to be DNR, DNI. And like, to watch that happen, I feel there's some joy from that. There really is some joy from that. And here, if you go back to our hypothermia schema, it was like the top three causes was exposure, sepsis, and hypothyroidism. And with the hypotension and the hypothermia, the DIC, the sepsis, and like sepsis would explain everything, and bacteremia would explain everything. If it was just a urine culture without bacteria, then I would be very cautious with saying, hey, this is all from a urinary source. But if you go and look at the data, like for bacteremia, and it depends on what organism, but like staph, there's like a 20% mortality rate. Someone can look up an Enterococcus bacteremia. What is the mortality rate? And this guy was down for 2 days and didn't come to clinical attention. And that's where the whole like early treatment is what dictates survival in sepsis. And this guy is septic shock. Like I assume at some point he got pressors. So is this outcome unlikely? No, unfortunately, it isn't unlikely. And he was immunocompromised. So everything can be explained from sepsis. It's just that his was hypothermia, not fever. And he had ARDS and he had DIC and he died, unfortunately. But let me give the mic back to you, Amal, before you pass it to Ambish to update it. Like, how did you process all of this? Like, what were your main takeaways?
Yeah, so we were like also eager to like work up more, but then the partner decided to like withdraw care. So we were like, okay, at this point we have to stop and like not be curious and know more, although it was like very interesting to us. But I agree, like the way we thought UTI, bacteremia, and then this caused like ARDS, DIC, and we were treating with antibiotics, and then he was just deteriorating. So unfortunately, he passed away. But I think this case was very interesting to me. I learned a lot from it, and I was trying to like broaden my differential, but sometimes like our clinical curiosity would like we have to like respect the patient's wishes, and at some point like stop and just let the patient like just respect the patient's wishes. So yeah.
Thank you so much for presenting. I think what I love these cases so much because it's bread and butter medicine. I'm sorry for the outcome, but this is where you want to be really good. You don't want to be an expert in diagnosing Erdheim-Chester disease. You want to be an expert in identifying sepsis, starting treatment, and having an idea of what the course is going to be. So and also it like helped us like think about hypothermia, which we often don't do, and having an approach to hypothermia. Ambish, the mic is all yours. You're waiting for your name to be pronounced.
Yes, I was. Thank you, guys. That was an interesting case with a lot of learning. As always, Prof. Red, I ran out of space on my whiteboard to put in all of that information, and then I start making notes, and then I'm panicking. But I'll just focus on some of the take homes for me. First of all, the emphasis is always on the history. So obviously you want to make sure that you take a detailed history, and history is always the king, and it gives you a lot of clues and cues as to how to progress and how to move forward with a particular case. And then Prof. Rez talked about the core foundations of a good diagnostic framework, which includes the 3 Ls, starting from the most likely to the most lethal and to the least likely. So within this patient, we started off with altered mental status. Before I move on, I would like to give a brief overview of the problem representation so that we're all, still on board. So we had a 60-year-old patient, male patient with a past medical history of chronic alcohol use, who presented to the ER with a 2-day history of altered mental status, fecal incontinence, shortness of breath that was reported by the partner, loss of appetite, as well as recent weight loss. He was found on the floor at a homeless shelter with a noted consumption of, with fecal incontinence. And the history was also prominent for a noted consumption of 4 beers a day with shots of vodka. Examination revealed irregular cardiac rhythm without a murmur, diffuse pulmonary crackles. There was a non-blanchable rash on the lower extremities and bilateral pleural effusions with atelectasis on imaging. Eventually, it turned out to be a lot of things going on with this patient, and sadly, he couldn't make it. He had DIC, ARDS, bacteremia, a history of UTI, and something that I was just reflecting on was that one of the portals for enterococci to enter the body is through the urinary tract or through the GI system. So moving on to the take-home points, the AMS, the famous mnemonic, myth mnemonic, Prof. Rez was focusing mainly on the metabolic and the toxin side of those things because of this patient's presentation. He was a chronic alcoholic, so metabolic comes on top, and then toxins. We were thinking, are there any other toxins? So initially, when you have a patient like this coming in with acute encephalopathy, with a history of chronic alcohol use, you want to think of some generalized initial labs, which would include a point of care glucose, urine toxicology screen. You want to check the alcohol levels to see how high of an alcohol consumption has this patient had. You want to check the sodium, calcium, the BUN, and always rule out, since this patient was found on the floor, you always want to rule out any head trauma. And for this patient, it would be a good thing to kind of go for the CAT scan to rule out a subdural hematoma, which could then also be responsible for augmentation in a patient this age. Then we were thinking about the plausible causes for AMS along with the fecal incontinence, and we were talking about acute encephalopathy, a seizure-related post-ictal state, myelopathy, and then I also picked out some of the points from the chat from Dr. Ravi, from Shreyas. I love how there is so much teaching going on, not just visually, but also in the chat. So Prof. has talked about how alcohol can cause colonic inflammation, which would then increase the bowel movements, and that could have been the reason why this patient had incontinence. Dr. Ravi mentioned how alcohol causes hypothermia, and then Shreya mentioned how it can also cause pancytopenia, which later on we saw in this patient. And then my last main take home for today is, sorry, Prof. Rez, I stole your notes, I screenshotted them, and then I put them in the on the whiteboard. I hope that's okay with you. So the approach, and if it's not, I can always move it later on. But the approach to hypothermia includes, number one, a repeat temperature assessment to verify whether this was an accurate finding. Number two, does the degree of hypothermia correlate with the clinical syndrome? If not, you want to look for an alternative diagnosis of this clinical picture. Number three, you want to see if there were any environmental exposures. Was it an accidental hypothermia? Were there any drug exposures? And number four, ruling out infections, hypothyroidism, and hypocortisolism, and then moving on to the lesser likely causes. And then a very, very important thing to keep in mind is when you're rewarming the patient, you want to do it in a gradual stepwise fashion, and there's different ways of doing it, both external and internal. And then we talk about MAHAs a lot, and the three most prominent ones are TTP, H2S, and DIC, and I guess that's it. I stopped typing after that.
First of all, I'm honored you took the 5-step approach. As always, such a brilliant job of really capturing the essential teaching points and also including teaching points from the incredible people in the chat. And if I did my own cognitive autopsy, I think the part where I struggled with in this case was step 2. Like, does the hypothermia explain that? And the reason I struggle with that is because I just don't see hypothermia enough to have a good grasp of like how how it might explain the clinical syndrome. But if you go back to the vitals and you see that hypotension, and if you use that as your anchor, and then you say, okay, what cause of hypotension can also cause hypothermia, then you're right back at infection and hypothyroidism and hypocortisolism. So it's really interesting case. I love this. It's like bread and butter. It allows us to glance on hypothermia, but always like prioritize infection, the hypothyroidism. So I really enjoyed it. Thank you for emphasizing those points. And Amal, thank you for bringing bread and butter. And I'm really glad that this patient died with dignity and the way that they wanted to die.
Yeah, thank you so much for having me, and I really enjoyed doing this. Thank you.
All right, Deborah, sign us out.
Thank you, everyone. Hope to see you all next week. Bye-bye.